My name is Mara Antonoff. I'm a thoracic surgeon at MD Anderson Cancer Center in Houston. I am a chair of the Council on Member Engagement for the Society of Thoracic Surgeons, and a lot of my passion in patient care and research surrounds lung cancer. Care for lung cancer is evolving very rapidly, and it has become more than ever multimodality. While surgery is still an incredibly important component of care for lung cancer, it's now really just a piece of the puzzle, and it's valuable for our STS members and all surgeons really to understand where surgery fits in the big picture. It's important that we're engaged at the level of the clinical trial as we think about taking care of patients in a multimodality fashion, and even as we think about how to advocate for our patients at a greater level in terms of approvals and opportunities that are available to really provide these new innovative cares to patients really all over. In order to advance our efforts for patients with lung cancer, it's important that we not only have innovative trials and novel techniques to take care of patients, but that we ensure that these new strategies are available for patients. That requires not only funding for these trials, but also approval to pay for these types of treatments once they do become available. I think for surgeons who take care of patients with lung cancer, it's incredibly valuable for them to understand that we need to be engaged in the development of trials, in the conduct of trials, and really following our patients once they've been enrolled in trials. Not only that, once we prove that a particular benefit is good for our patients, we need to ensure that these changes, this innovative care, can be delivered to patients really throughout our country.
I'm Jessica Donington. I'm a general thoracic surgeon, and I serve as the second vice president for the Society of Thoracic Surgery. So the most exciting advancements in thoracic oncology in the most recent years has been the introduction of targeted therapies and immunotherapy into resectable non-small cell lung cancer. In 2025, we saw the final reports from two really landmark trials, the Checkmate 816 trial using neoadjuvant chemotherapy and nivolumab, and from the Keynote 671 using perioperative chemotherapy and pembrolizumab. Both of those trials showed a definitive improvement in 5-year overall survival with the addition of immunotherapy to surgical care. This has been a landmark change in how we treat surgical patients with resectable stage 2 and 3 disease. The next wave is all about how do we pick the exact therapy for each patient and better maximize an already good therapy. In the end of 2025, we heard the results from a really exciting trial for surgeons called MDT Bridge, looking to see, do these really amazing treatments change how we looked at resectable disease? Can more patients become resectable because of their really impressive responses to these medicines? I think this is a landmark change for how I should say we, treat locally advanced non-small cell lung cancer. Two really exciting trials which are going on now to better refine who gets immunotherapy and how we deliver it come out of the Alliance and one of our NCI cooperative groups. First is the Prospect trial. It looks at giving chemoimmunotherapy either before or after surgical resection. I think this is a particularly important question for patients with stage 2 disease, where the standard of care may really be shifting, and this trial may help us either verify that shift or continue the controversy. The second trial from Alliance is called the Insight trial. So one thing we've noted is that patients who undergo chemoimmunotherapy and have no residual tumor left at the time of resection, what we call a pass CR, those patients may not need further immunotherapy after their surgery. This trial will randomize patients who have a pass CR to either getting more immunotherapy or just observation. So again, further refining what those first trials put out. These trials are from the Alliance, one of our NCI-sponsored cooperative groups. There are many trials which pharmaceutical companies are never going to undertake, but are so important to the care of our patient. And this is where the NCI comes into play. And keeping funding for these is really important for how we treat our patients going forward. Advocacy is such an important part of what the STS does. Having a call to action on the Hill in DC to make sure the NIH and all of our initiatives remain funded is an important part of what we do and what we need each of our members to be engaged in.